In this lecture video, I will discuss about paraneoplastic neurological syndrome. These paraneoplastic neurological disorders spans from cognitive and encephalitis disorders to peripheral and neuromuscular syndromes. Diagnostic criteria updated in 2021 used paraneoplastic care score to classify neurological syndromes into definite, probable, possible and non-paraneoplastic syndromes. These are based on the presence of high risk, intermediate risk or low risk phenotype, antibodies and cancers requiring long-term follow-up with repeated evaluations for cancers. This figure explains the pathophysiology of paraneoplastic disorders. These tumor cells are undergoes apoptosis by CD4, CD8 cells, and these B cells further matures into plasma cells to produce antibody against these tumor antigens. And these antibodies or cytotoxic CD8 cells slow the growth of tumors, as well as the portion of it reacts with the CNS outside the blood-brain barrier, and the plasma cells and cytotoxic T cells crosses the blood-brain barriers and attacks the neuron expressing the antigens that are shared by these tumors, leading to the paraneoplastic neurological disorders. 2021 updated diagnostic criteria for paraneoplastic neurological disorders include the clinical phenotypes. These are given various points. The phenotype with high risk of cancer associations, these are given 3 points, and these includes limbic encephalitis, encephalomyelitis, opsoclonus myoclonus syndromes, rapidly progressive cerebellar syndromes, sensory neuropathy, Lambert-Eaton myasthenic syndromes, as well as GIT pseudo-obstructions. These are given 3 points, and they have the high risk of cancers association. The phenotypes that are given have intermediate risk of cancers associations that are given 2 points, and these include encephalitis that are not limbic one, brainstem encephalitis, Morvan syndrome, a stiff person syndrome, isolated myeloradiculoneuropathies, not CIDP or GBS, and phenotype not associated with cancers are given 0 points, all other clinical presentations. Then the laboratory testings with the cancer associations. The antibody with high risk of cancer association are given 3 points, and they have greater than 70% of the associations, and it include anti-neuronal nuclear antibody type 1 HU, Purkinje cell cytoplasmic antibody YO, Purkinje cell cytoplasmic antibody 2, and various notch-like epidermal growth factors related receptors, collapsing responsive mediator protein, amphiphysins, NMDA. These are given 3 points. The antibody with intermediate risk of cancer associations, there are given 2 points, and it include, and they have the cancer association between 30 to 70%, and it include AMP antibody associated, GABA B associated, metabotropic glutamate receptors 5 and Caspar-2 antibody associated. And the antibody with low risk of cancer association, these are given 0 points, and they have less than 30% of the cancer associations, and these include GABA A, Casper2, glial fibrillary acid proteins, glial as well as GAD65. These are given 0 points because they have the low risk of cancer association. Then cancers or tumors found are consistent with the phenotype antibodies are given 4 points, like U antibody with breast carcinoma, ANA1 hue with lungs carcinoma. They are given 4 points. Not found or not consistent include ANA1 hue and no cancer found or repeated screening, GAD65 and prostate cancers. These are given 1 point, and not found on 2 years of the follow-up. These are given 0 points. So, based on these 3 phenotypes, antibodies and association of antibody with the cancers, we have the definite, probable, possible and non-paraneoplastic disorders. For definite paraneoplastic neurological disorders, there should be 8 or more points. For probable, we have 6 to 7 points. For possible, we have 4 to 5 points, and non-paraneoplastic disorders with 3 or less points. So, on this we can categorize the paraneoplastic disorders being definite, probable, possible or non-paraneoplastic. Clinical evaluations for paraneoplastic disorders include prodromal symptoms of paraneoplastic disorders are fever, upper respiratory tract infections and symptoms, GIT symptoms shortly before neurological symptoms, followed by acute to subacute progression of neurological symptoms. The sleep disorders such as insomnia, hypersomnia and parasomnia are common with LG-I1 encephalitis. The family history of autoimmune disease is more common in patients with paraneoplastic syndromes. Then paraneoplastic syndromes with high risk of cancers. High risk of paraneoplastic causes. Neurological syndromes with high risk of paraneoplastic causes include limbic encephalitis with NMDA and AMNA receptors encephalitis, opsoclonus, myoclonus syndromes, cerebellar syndromes, sensory neuropathy, Lambert-Eaton myasthenic syndromes. These are the this flowchart. This table summarizes the mimics to be considered with the patients of paraneoplastic neurological disorders, and this includes these mimics include leptomeningeal metastasis, skull-based metastasis, herpes, various infections like herpes simplex and other encephalitis like herpes, human herpes viruses, then thiamine deficiency, non-convulsive status epilepticus, botulinism, Guillain-Barré syndromes and myasthenic crisis. Other include the toxins like fluoroquinolones, chemotherapeutic toxicities, capecitabines, pituitary insufficiency with apoplexy, CZD, gluten ataxia as well as genetic mitochondrial syndromes or glucose transporter type 1 deficiencies. So, these are various mimickers of paraneoplastic disorders. that should be considered while we are making a diagnosis of paraneoplastic neurological disorders. Then paraneoplastic encephalitis with seizures. These include, if the limbic encephalitis, the causes include NMDA, encephalitis, antineuronal nuclear antibody type 1, that is HU, AMPA associated encephalitis, MA1 and MA2 encephalitis, leucine-rich glioma, inactivated protein 1, GAD65, glial fibrillary acid proteins, Caspar-2 associated encephalitis. So, these are the paraneoplastic limbic encephalitis syndromes that are associated with seizures. This table summarizes various paraneoplastic limbic encephalitis syndromes like NMDA associated encephalitis, then HU associated encephalitis, AMPA associated encephalitis, MA1 and MA2 associated encephalitis, leucine-rich glioma, inactivated protein 1 associated encephalitis, GAD65 and glial fibrillary acid protein associated encephalitis. Then here in this MRI we can see the marked hypermetabolism in bilateral mesangial temporal lobes in figure 1 and A and B, and hypothalamic as well as enhancement of mammillary body in figures C and D. These are the patients of limbic encephalitis. Then cognitive outcome following paraneoplastic encephalitis include 2022 meta-analysis of literatures on neuropsychological assessment across several types of autoimmune encephalitis confirmed that significant neuropsychological symptoms burden persist even after improvement from therapy with the patients of paraneoplastic encephalitis. Means the cognitive decline even persists after we have treated these patients. Then movement disorders associated with various paraneoplastic neurological disorders include Parkinsonisms with ANA2, that is re-antibody, MA2 antibodies, then chorea and dystonia with HU antibody, Caspar-2 antibody, colespin responsive mediator protein 5, that is CRMP5, and LGI1 syndromes. Then glial fibrillary acid protein astrocytopathy have the movement disorders often exist are ataxia, tremor, myoclonus, and rarely opsoclonus and ocular flutters. These can be associated with glial fibrillary acid protein astrocytopathies. Then CJD can have a overlap clinical symptoms, especially with LGI1 syndromes. Glucose transporter type 1 deficiency have episodic attacks with seizures and movement, various movement symptoms like chorea. Then ophthalmic syndromes that can be associated include cancers associated retinopathy with enolage and recovery in transient receptors, potential cation channel subfamily M. Then progressive painless unilateral or bilateral vision loss in recovery associated ANNA1, that is HU associated, GAD65 associated, LGI1 associated, NMDA and glial fibrillary acid protein antibody associated. Then optic neuropathy with subacute dementia, ataxia and neuropathy, we can consider the diagnosis of CRMP5 associated syndromes. Then opsoclonus myoclonus syndromes. Opsoclonus myoclonus syndromes can occur as a part of para-infectious or autoimmune disorders, but is also associated with underlying neuroblastoma. As opsoclonus or ocular flutters can be a part of Hue or Re syndromes, antibody Hue or Re syndromes, or ocular clue to some of the paraneoplastic syndromes include dawn-beating nystagmus with ganglionic glare thinnings on OCTs in a stiff person syndromes with high titer of GAD65 antibody. Anti-nicotinic acetylcholine receptors antibody can have pupillary dysfunction with light sensitivity in addition to autonomic GIT and bladder dysfunction. This table summarizes various paraneoplastic brainstem syndromes, and these include Purkinje cell cytoplasmic antibody 1, that is EO, or Purkinje cell cytoplasmic antibody 2, or antineuronal nicotinic receptors antibody, MA1 and MA2 antibody, IG-Lons family protein 5 antibodies, antineuronal nuclear antibody to dipeptidase peptide-like antibodies, GAD65 antibodies, and leucine-rich antibodies. This MRI explains that there is hyperintensities in the midbrain and tectum in figure A and B, whereas there is marked cerebellar and brainstem atrophy as well as atrophy of the middle cerebellar peduncles and in figures C and D in a patients with paraneoplastic brainstem syndromes. As well as brainstem encephalitis is associated with hypertrophic olivary degenerations in figure E and F. Then various cerebellar syndromes associated include anti-PCA, that is EO antibody with paraneoplastic cerebellar syndromes. GAD65 antigens are common in patients with type 1 diabetes and at low levels are non-specific, but high titers of greater than 2000, they may be more likely to be associated with clinical neurological autoimmunity. This table summarizes various cerebellar paraneoplastic syndromes, and these include Purkinje cell cytoplasmic antibody 1, that is EO, and cerebellar degeneration related protein 2, Purkinje cell cytoplasmic antibody 2, SR by box transcription factor 1, delta or notch like epidermal growth factor related antibodies, Kelch-like protein 2, metabotropic glutamate receptors 1, and IG-Lon family protein 5, family member 5. These are some of the cerebellar paraneoplastic syndromes. Other include contactin associated proteins 2, antineuronal nuclear antibody 2, GAD65, dipeptidase peptide-like protein 6, neuronal intermediate filament light chain proteins, and rogue GAD activating proteins 2,6, and glutamate inotropic receptors kinase type subfamily 2. So, these are some of the antibodies that are associated with cerebellar syndromes. Here we can see there is marked hyperintensities involving both cerebellar hemispheres in figure A and B, and FDG PET shows marked hypometabolism in left cerebellar hemispheres in figure E and F. Then myelopathic syndromes associated with paraneoplastic disorders include Myelitis can be a part of HU, aquaporin 4, MOG associated, glial fibrillary acid protein associated, CRMP5 associated, amphiphysin or ANA2, that is re-associated, or GAD65 associated. Atypical infections are the cause of myelitis, can also mimic paraneoplastic disorders in immunosuppressed patients like varicella zoster or herpes simplex virus. Longitudinally extensive transverse myelitis with aquaporin 4 associated syndromes. Here we can see the long segment of enhancement involving lateral column of the thoracic spinal cord, and there is increased T2 signals and marked abnormal FDG uptake in the spinal cord in figure D and E. Whereas in figure F and G there is increased T2 signals and enhancement of the lateral columns, which are suggestive of various myelitis. Then Stiff-Person syndromes can be present with high titer of GAD65 antibodies. Anti-glycine receptors antibodies have progressive encephalomyelitis with rigidity and myoclonus. Distal limb presentations with anti-amphiphysin antibodies, dipeptidyl peptidase like protein 6 or GABA A receptors associated encephalitis. Then peripheral nerve syndromes include subacute sensory neuropathy with asymmetric patterns with HU antibody associated, mononeuritis multiplex sensory motor neuropathy with CRMP5 or antineuronal nuclear antibody type 3 or anti-Purkinje cell cytoplasmic antibody type 2. And acute motor neuropathy, autonomic neuropathies are associated with HU antibodies or anti-Purkinje cell cytoplasmic antibody 2. Peripheral nerve hyperexcitability in Morban syndromes with Casper2, anti-LGI1 or anti-netrin-1 antibodies. Anti-Klitsch like protein 11 associated antibodies are also seen with brainstem or cerebellar syndromes, are associated with testicular seminoma causing myeloneuropathy syndromes. So, in these antibody, peripheral nerves are involved, leading to various peripheral nerve symptoms. IgM monoclonal gammopathies of undetermined significance can cause demyelinating patterns that are more responsive to immunotherapy, while IgG and IgA tends to have less frequent association and with axonal neuropathies. Waldenstrom's macroglobulinemia are associated with anti-myelin associated glycoprotein antibodies causing painful sensory loss in legs with sensory ataxia. Multiple myeloma, which causes lambda amyloid neuropathies, especially carpal tunnel syndromes with painful diffuse sensory motor neuropathies. Poems with rapidly progressive neuropathies are similar to CIDP's symptoms is caused by underlying solitary plasmacytoma. This table summarizes paraneoplastic peripheral neuropathies, and these include subacute sensory neuropathies, sensory motor neuropathies, polyradiculoneuropathies, motor neuropathies. Then various myasthenic syndromes associated with paraneoplastic disorders include Lambert-Eaton myasthenic syndromes is associated with voltage gated calcium channels associated antibodies and as well as anti-SRY box transcription factors 1 associated antibodies. Myasthenia gravis with anti-acetylcholine receptors antibodies have 10 to 15% association with occult thymoma, and up to 70% patients have focal thymic germinal cell hyperplasia. Thymectomy has been shown in a randomized control trial to help achieve symptoms control in as well as in non-thymomatous patients. That is, thymectomy even in non-thymomatous patients, patients with myasthenia gravis are shown to have symptomatic improvements. Majority of these patients have anti-acetylcholine receptors antibodies, although anti-titin and other antibodies have been reported, which can produce severe bulbar and respiratory symptoms. Autoimmune autonomic ganglionopathies is associated with neuronal ganglionic alpha 3 or alpha 4 acetylcholine receptors, and this patient can present with orthostatic hypotension, constipation with Zika syndromes, anhidrosis or autonomic bladder dysfunctions. Muscle syndromes include dermatomyositis are associated with underlying malignancies like GIT, ovarian, nasopharyngeal or breast. Honeycomb edema on MRI on quadriceps muscles have also been associated with 85% increased risk of malignancies. Dermatomyositis and antinuclear matrix protein 2, melanoma differentiated associated protein 5 and anti-transcription intermediate factor 5 antibody have been associated with increased risk of malignancies. Seronegative necrotizing autoimmune myelopathies has also been associated with occult malignancies. The treatment principle include involving the combination of underlying malignancies, treatment of underlying malignancies with immunomodulators. Focal breast cancers should undergo neoadjuvant chemotherapies prior to resections, but in presence of paraneoplastic disorders, tumor removal is paramount. That is, tumor should also be removed along with resections of the cancerous tissues. Then we have the concept of antibody negative paraneoplastic neurological syndromes. Alternative diagnosis as well as more invasive oncological and neurological testings should be considered, and family history and social history as well as repeated detailed systemic examinations for findings suggestive of other disorders is crucial in antibody negative paraneoplastic neurological syndromes. Thank you all for watching my lectures.